Good afternoon and happy Friday. We've got a group in the room. As you all can see, we've got, I think we had about 18 people online.
21 now.
Joining us for the Health and Economic Outcomes Accountability Oversight Advisory Panel Informational Meeting. We appreciate everybody taking some time this afternoon. We're going to go through the latest quarterly report and have a chance to hear from our providers as well. And we also are going to talk about the quality metrics discussion. All the things that are on the agenda are things we're going to touch on, but I want to open us just by saying that these meetings are very helpful to us as we go through the overarching Medicaid sustainability review process that we started at the beginning of this year, while we're taking a look at all the different components of our delivery system to understand how we can make improvements. So we just appreciate everybody's time in doing that and walking through, and I will kick it over to Nell Smith to go ahead and go through the quarterly report.
Thanks. If the panel members were sent a copy of the quarterly report, now I can't. Oh, hold on. There we go. It's on
Working.
It's
Okay.
on, yeah. Okay, we've got advisory panel members online joining via Zoom. And just a reminder, we've also got, we're live streaming this meeting thanks to PBS, Arkansas PBS, and you can watch that live stream now. Some people may be joining that way, or there will be a recording later on the ARCAN website, and there's a link to that in the slides, which will be also posted online. Christy already, Secretary Putnam already talked about the topics that we're going to be talking about today, so I'll just get right to the first thing, which is the quarterly report. This is a report that is statutorily required, and the panel members have already received a copy of that. I'm not going to go into depth on that. But it's there for you in case you're interested in reading the latest numbers. It's also going to be posted online at our ARHOME website. I'm going to talk about two things. One is the ARHOME enrollment, and you can see that we are down in December to about 240,000 people enrolled in ARHOME. That's people who are enrolled in a QHP, but also people who are medically frail and part of our medically frail group that receives services through Medicaid fee-for-service. That is down about 31% since January at the height, and this decline is due to our unwinding of the public health emergency. We, as many of you know, we had, because of the COVID public health emergency, we were unable to disenroll individuals during the public health emergency. And then beginning at the end of March, we started disenrolling individuals who are no longer eligible for Medicaid. And that has ended in September. But we are still seeing some impacts of that. So this is a representation of the expenditures, and this is not including the Medicaid, the medically frail individuals. This is just the individuals who are in a QHP. So the blue bars represent the premium paid, the premium that DHS paid to the QHPs during each quarter, beginning with Q4 of 22. And then the orange bar represents advanced cost sharing. This is our effort this is money that we pay upfront, an estimated amount, to offset the cost sharing that Medicaid clients would pay. They don't pay a $50 copay as people would on the marketplace. They pay a $4.70 copay. So DHS makes up the difference for that. And so we pay a portion up front. So that's what that orange bit is. But you can see that overall, the total payments to QHPs dropped from about $657 million in the first quarter of 23 to 447 million in Q3. That's a 27% decrease. The line across the top is the per member per month cost. We had it increased from Q4 to Q1 just because we changed the estimated percentage of the premium that we would pay. We changed it from 35% of the premium to 40% of the premium. But you can see as we've decreased costs, our per member per month amount is going up a little bit, and that's likely because we're losing the least expensive people, the young people, the non-smokers. So I will move along to the main part of the event today, and that is our health quality measure results. Just as a reminder, these metrics, performance metrics, were set in 2022, in December of 2021, and we're going to be reviewing the 2022 performance targets. In September, we looked at 11 health metrics, and though we had an issue with incomplete data for one of the carriers, so we had to split that between 2 meetings. And so today we'll continue the review of the other performance metrics that we have on tap, and then we will review the QHP's health incentives that are related to those metrics. So, and again, as a reminder, the health improvement initiative requirements, we required the QHPs to offer 1 health improvement incentive for each of the focus areas that you see in the bullets. And then in 2023, we upped that, and we required them to offer 2 incentives for each of those populations. And then the QHPs also have to include activities to support the health improvement initiative in their annual strategic plans, and you'll hear those annual strategic plans today. So this slide the ARHOME program is an 1115 waiver. It's a demonstration program. It's a demonstration program so that we can set it up in this way where we're paying the QHPs for providing services rather than the regular fee-for-service structure. And because it's a demonstration program, CMS requires that we have an evaluation. So our evaluators, GDIT, who are behind me, have already surveyed our clients to see what they know about the incentives. So the first question is, did your health plan offer you any reward for healthy behaviors or wellness screenings? And you can see that only less than a quarter said yes. So both carriers, all 5 QHPs were offering incentives, but clearly it looks like folks really just weren't aware of it. And then the next question was asked of the people who said yes to that first question. Did you know that these rewards and credits are part of the ARHOME program to improve the health of members? And 65% of those people said yes. So I think we have some awareness issues that we need to take care of, and we're hoping that the QHPs will engage in that.
There was a question in the chat from Alyssa asking what was the sample size?
It was 200, we had 215 people, and 205 of those were analyzable. We sent out, and you guys can tell us, they sent out a lot of surveys, 3,000, something like that, and just didn't get a very good response.
A very large
response. And they tried several different ways. They tried several mailings and then emails and then texts, and just didn't get a very good response.
That's consistent.
Yeah. That's why they don't know that.
So we're going to go through the incentives, the metrics, but this is a repeat of a slide you guys saw last in September. And this is really just to show that the populations of the 5 QHPs. We've got 2 that are operated by Blue Cross. Those are in blue, creatively. And then we've got 3 from Centene, and those are in green. The red is ARHOME overall. But you can see in the different subgroups, they're roughly very similar, in terms of poverty, terms of gender, terms of rural and urban, and by race. But they are considerably different in terms of the age group. We have the Health Advantage QHP that has a younger population, and then the Blue Cross plan has the oldest population. So, and age is significant in some of these. So preventive care. We have 3 preventive care measures, but I'm just going to share one today, and that's the breast cancer screening. We did do cervical cancer screening last time, and then there's a chlamydia screening that we've got available in your quarterly report if you're interested. So this is breast cancer screening. This is the percentage of women ages 50 to 64 who had a mammogram in the last 2 years. And this slide shows the trend from 2019 to 2022. ARHOME, again, is in red, the ARHOME overall. The race breakdown is in blue, and urban and rural is in green. And after some declines in the rates from 2019 to 2021, we saw an increase, a good increase in 2022. We don't have the 22 national numbers to compare with our 22 ARHOME rates, but we do have 2021, and ARHOME as a group didn't do as well as the 2021 Medicaid median of the reporting states. We ranked 36th out of 46 reporting states for breast cancer screening. The interesting thing to me here is for all of the preventive screening measures, Black women did better than white women. I think that's, and I think you sent me something this week that found that nationally.
Medicare Advantage, same thing.
And that's Bill
They
Golden.
found it nationally.
Yeah.
That's different than what we've seen in past years, isn't it? Or is it?
No, they just basically, for reasons that I can't explain, the Hispanic and Black patients got more preventive services in women than whites in Medicare Advantage nationally. Not true in the male services, but that's a different story.
So this is, we're about to see the results for breast cancer screenings by QHP. So just as a reminder, this is a slide that shows the incentives that each of the QHPs provided. And I've got highlighted the mammogram because that's we're going to be seeing breast cancer screening. And you can see that that Blue Cross offered $50, Centene offered $25, and Blue Cross actually had better uptake of that incentive than the Centene plans did. Oh, and I will say, last time we didn't have the Centene percent of eligible receiving, and they were kind enough to get us that information. So this is breast cancer screening by QHP. And on this slide, you'll remember that each of the bars is a different year, and then we've got them grouped by the QHP. Health Advantage only came into being in 2021. You have to have 2 years in a health plan to even be eligible to be considered for the measure, so they don't have any data for 21 or 22. They will for 23. Let's see. So Blue Cross did a better job than, or had better rates than the Centene plans, and it may or may not be related to the higher incentive and the higher uptake in that incentive. We see that some places that it's true and some places not so true. Were you about to say something?
I was gonna say the dip in 20 and 21 is probably COVID related,
Right.
so now we're seeing it come back up.
Mhm.
It should still be better.
So this is, this is just for the non-attending audience, just a summary of things we've already talked about. Next is contraceptive care, and we're gonna look at contraceptive care for postpartum women and for all women. So this is a percent of postpartum women ages 21 to 44 who had, my watch is telling me they found some research on optimizing postpartum care. Thanks, watch. Women ages 21 to 44 who had a live birth and who were provided a most effective or moderately effective method of contraceptive within 60 days after the birth. And the most effective methods are LARCs, implants, intrauterine devices, as well as irreversible surgical contraceptive. And then moderately effectives are injectables, oral pills, patches, rings, and diaphragms, in case anyone heard. So the ARHOME rates for this measure decreased and then increased in 22. I will say, sorry, I'll take that back. The increase that you're seeing there in 22 is related to a metric change. The measure changed from 60 days postpartum to giving an extra 30 days. So the increase is largely due to the metric change. We did have GDAT run that at the 60-day mark as well, just to see what would happen, and it was a continued decrease, so. So this is the, based on the QHPs. And you can see that even with the additional 30 days that are included in this metric, none of the QHPs met the 2022 target. The highest postpartum conception rate each year switched back and forth between the 3 Centene plans, so there wasn't a standout plan. Oops. So this is the contraceptive care for all women. This is a percentage of all women ages 21 to 44 who were provided a most effective or moderately effective method of contraception. And I scaled it to be similar to the previous slides so that you can see that we've got about half of the postpartum women received contraceptive care, while only about 20% of all women received contraceptive care. I think I can understand why. So like the contraceptive rates for postpartum women, the ARHOME rates for this measure continue to decrease since 2019. And the ARHOME rates are worse than the national median Medicaid rate for this measure. Urban rates are better than rural rates, but only slightly. And there's not as much difference between urban and rural in this measure as there was for postpartum. And similarly, Black women have slightly better rates on this measure than white women, while they had lower postpartum rates than white women until that measure changed. This is by QHPs, and with the continued decline, none of the QHPs met the 2022 target. The Blue Cross plan had the highest contraception rates for all women for all 4 years. Skip that. So now we are talking about substance use and behavioral health, other behavioral health. These are the incentives. These are the incentives for substance use disorder. Substance use disorder was one of the specific populations that we asked the QHPs to address. Blue Cross had I think it's a $65 to $70 award for individuals who had a follow-up visit after hospitalization for substance use disorder. They had, low uptake of that, 12% of eligible, and 10 or 6% of eligible. The Centene plans didn't offer a specific incentive for substance use disorder. They've included sort of mental health activities that could be done, videos that could be watched on their portal, and really didn't have great uptake there either. So this is follow-up after an ED visit for alcohol or other drug abuse. And it's if you received follow-up with a mental health provider 30 days, within 30 days of the ED visit. And this is, Janet gasped when we saw this, and it was, I had to explain that the methodology changed and included additional procedure codes that are more consistent with behavioral health measures. This was not a change that we made. This was a change that it was made by HEDIS, but it looks like we did something really fantastic in 22, but alas, we did not. But we can say, while we can't compare year over year, we can say that as with many of the metrics for mental health treatment, white clients had better rates than black clients, and rural clients had better follow-up rates than urban clients. This is by QHP of the same measure, and the Blue Cross plan had significantly better follow-up rates than any of the other plans. All right, so this is, we've got initiation and engagement of alcohol and drug abuse treatment. So this is the percentage of clients with a new episode of alcohol or other drug abuse or dependence who initiated alcohol or other drug treatment within 14 days of that diagnosis. Treatment includes inpatient alcohol or other drug admission, outpatient visit, intensive outpatient encounter, etc. So the ARHOME rate in 2021, again, we don't have national numbers for 2022 yet. So comparing ARHOME to the median, the Medicaid median, we're lower than the national median. We don't do as well in this as nationally. The urban and rural rates are just about the same each year, but the urban rate increased a little more than the rural rates in 22. And I will also point out the issue with the more procedure codes. Did we have a question?
Yeah. Sorry, I'm having to listen into this meeting. And yeah, sure. So that's a good question. So my daughter is on waiver, and we got this paperwork in the mail yesterday, and it said it's due Monday. So kind of a short turnaround. It said we could mail it or turn it in person. So I'm just needing to turn this in. I don't know if you can. Yeah, I don't know if you need the envelope. You don't need anything?
Hold on. I think I can.
Perfect. Thank you. Thank you. I think that's everything you need. My wife usually fills it out. I'm just dropping it off.
It's late, yeah.
I texted him.
Sorry, I bid it to put it in the envelope. I probably should have left it straight. Thanks.
Hey, Lee, it's Janet. You're not mute. There you are.
We do know how his day's going.
We do. That sounds like fun work.
And he's having to listen to this ARHOME call.
He has something to do.
Very exciting. All right. So one thing that's affecting these rates is you remember we saw the giant increase in follow-up after ED visit for SUD. And that was due to procedure codes. that is playing into this as well, but it did not affect it as much as it affected the other metrics. So the gains that you're seeing here in 22 are, I don't want to say likely, but probably related to some additional codes being used. Or we're doing fantastic, one of the two. So our Medicaid, sorry, did I talk about where we are? Oh, I said ARHOME is lower than the national median rate. And white clients, again, initiate treatment at significantly higher rates than Black clients. There we go. Okay, this is by QHP. There's little difference in the rates among the QHPs in initiation, but 2 of the Centene plans met the established target, perhaps helped by the additional procedure codes. Okay, this is engagement. So the first one was initiation within 14 days. This is, are they still engaged? They were initiated at 14 days, and 34 days later, they're still receiving treatment. And again, you can see we dropped a number of percentage points from initiation to those who are still engaged. The ARHOME rate in 2021 is below the 2021 national median of reporting states. ARHOME was 11.7%. The national median was 15.8%. And just like the initiation of treatment, we continue to improve in the engagement of treatment since 2019. And again, white clients had greater engagement rates than Black clients. This is by QHPs, and 4 of the 5 QHPs met the established target. And so while there was little difference in the QHPs in initiation, the Centene plans had higher rates than the Blue Cross plans in engagement. And that's for the non-attending audience. Okay, this is the last 2, and these are related. Antidepressant medication management, there's the effective acute phase treatment, and that's people who are diagnosed with major depression who were treated and remained on an antidepressant for 12 weeks. So there was improvement on this measure each year between 2019 and 2021, but the ARHOME overall rate dipped in 22. Urban and rural beneficiaries have about the same rates of antidepressant medication management. But as we've seen with other mental health treatment measures, white beneficiaries have significantly better rates of antidepressant medication than Black beneficiaries for all 4 years. And ARHOME does slightly worse, although it's very close, than the 2021 Medicaid median of reporting states. Okay, so this is by QHP. 3 of the QHPs met the 2022 target, while 2 did not. Although, Qual Choice just barely missed the target. Okay, so that was the acute phase. This was the first 12 weeks. This is for 6 months, people who were treated and remained on antidepressant medication for 6 months. And the rates dropped from antidepressant medication in the acute phase to continuation phase by about 19 percentage points. Overall, the rates decreased in 2022 after some previous gains, following the same pattern that we saw in the acute phase. There was little difference between rural and urban rates, but again, white clients had significantly higher rates than Black clients. And ARHOME does about the same as the 2021 Medicaid median of reporting states. This is by QHP. So just one QHP, Blue Cross Blue Shield, met the 2022 target, although Ambetter came very close. Okay, so that is the end of the metrics. This is a summary of where the QHPs fell in terms of meeting the targets. And these are just for the ones that we looked at today, plus some that were completed for the December meeting, weren't ready for the September meeting, but across all the metrics, just as sort of a generalized statement, the QHPs met the targets for metrics that measured management of chronic disease, treatment for opioid disorder and limits on opioid prescriptions, and follow-up after an ED visit for substance abuse and engagement in substance abuse treatment. The QHPs generally did not meet the targets for preventive screenings, contraceptive care, and follow-up after an ED visit or hospitalization for mental illness. So, and that whole list is in the quarterly report, broken down like this, but in the with all the metrics. Okay, I don't know if we have any questions or want to just
Questions,
keep going. Corrective action plan. So our MOU with the QHPs allow us to ask the QHPs to do a corrective action plan. So this is our plan for asking them to develop their own corrective action plan. We're asking them to describe for each of the measures that they missed, the reason that they believe the target was missed. And then we want them to tell us how they're going to change, how they're structuring their incentives or what changes they're making. And Dennis Smith did some work on some literature review on what incentives work for Medicaid clients and when they work.
Thanks, Nell. Just very briefly looked at a number of different studies over the last several years, including Medicaid incentives for prevention of chronic diseases, which CMS awarded grants to 10 different states. The states themselves picked which kind of approach they wanted to take. A lot of them on smoking cessation, weight loss for diabetes control were some of the most popular ones. Then looked at the state of Wisconsin, which did a several year study on do incentives work for Medicaid members. They did their own pilots within the state of Wisconsin, but then also looked at Florida, West Virginia, Kentucky, Idaho, and Virginia. So interestingly that and some were adults, some were children. So to try to get children involved as well. Really the lessons learned were incentives do work. The larger the incentive, more likely to have the result that you're looking for. The reward needs to be simple, both simple to understand, simple to access. There was one state in particular had a very sophisticated incentive reward system, but nobody knew how to use it. They earned rewards that they didn't know how to cash in, so to speak. So again, a lot of patient education is very, very key to making these work, that people know about it. They're simple, immediate, and again, there was a lot of frustration of why is it taking 6 months to be able to do an award that I earned quite some time ago. Rewards also reinforce continuous behavior. So as you pointed out, you had initiation, but then engagement, over a longer period of time, that behavior drops off. So if you really want to change it, you have to continue those to bring people back again and again and again, whether it's somebody to do a doctor's visit or a checkup or whatever. And then finally, marketing is an absolute must. They must be aware of the incentive, how it works, and how to access it. So again, multi-year studies, multi-states, taking multi-approaches. Things that are in control of the individual is very important, like getting prevention, participating in a preventative behavior. That's completely within the control of the individual. Other things are less in their control. If you do have to go to the emergency room, if you do get admitted, that's out of the patient's control, right? So somebody else is making that decision.
So that is how we got to the bullet points of the things that we're gonna be asking the QHPs to describe, which incentive is offered to ensure the improvement in the metrics, the incentive immediacy that Dennis was just talking about, beneficiary engagement, including culturally appropriate educational materials, and an outreach plan specific to Medicaid beneficiaries, and sustained communication, which I think is a big one, including the changes to frequency and incentive messaging. And then the magnitude. I know we've talked a little bit last time about changes that the QHPs are thinking about in terms of what they're gonna be changing, what sort of incentive they're gonna be offering and the value of that. And we're gonna be asking the QHPs to describe their plans for measuring their impact of the incentive changes. It shouldn't just be us. We wanna make sure that they're watching it as well. And finally, the corrective action plan will need to be approved by DHS. Unless the panel members have any objections to that. That's the plan. So the other piece is setting targets. So just as a little history here, in 2022, the targets were based on just one thing, the rate of the best performing qualified plan across 2019 and 2020. In 23, we expanded the sorts of targets that we were looking for. We had the best performance target, and you can see just as an example, that would be the one in green for contraceptive care. That's the best of all of the plans, and it's the best of all of the years. We also added, at the request of the QHPs, a median target, so that even if they're not reaching that high target, they've got something else to shoot for. And that was the median of all of those different values across the years. And then finally, they also requested an improvement target. So we asked that each QHP improve its best performing year by 4% during 2023. And then we set up a system of points for each of those, hitting each of those types of metrics. So for example, they might get 2 points for hitting the best performance. They might get 1 point for hitting the median target, and they might get 1 point for the improvement target, for a total of 4 points. And then we set up a system of, in the table below, you'll see the system of points and the value. If they achieve 50 points up to 108, which was the total allowable, they would have no penalty whatsoever. If they hit the other bars for points, they would receive a penalty of the differing values per member per month. So that's the way we set it up for 23. For 24, we are suggesting continuing with the best performance target, the median target, and making the improvement target improvement of its best performance by 5%, and we're also increasing the 24 penalties.
And to clarify, it's just percent, not percentage point?
It's percent, it's not percentage point. Yeah.
Okay.
And that leads us to the, the carriers, their strategic health plans. I don't know who wants to go first. Want to, doesn't matter.
You want to table?
Lauren's gonna
Okay.
drive for us this time. Thank you.
You can actually, if you want, I've got mine that I can talk through as well.
Oh, I stop sharing. Did it come up?
It came up.
No, what can I do? Share screen.
Did you want to welcome Jordan?
Yeah, I thought about that. We need to do that.
We can pause and do that now.
Yeah.
One thing that we wanted to do at the beginning, but we're going to do it now, just briefly, we wanted to welcome Jordan Burgess as a new member to this advisory group. So Jordan, welcome. Thank you very much. And if you would like to say something to the group, we welcome you to do so.
Can you hear me?
Yes, we can.
Okay, great. Well, just want to thank you all for having me. Looking forward to being a part of the group.
Thank you. We're grateful that you said yes.
Okay. So the Arkansas Health and Wellness,
I should have introduced you.
I can introduce you.
This is Kim Suggs from Centene, and she's going to talk about the 3 Centene plans.
All right. For the 2024 ARHOME strategic plan, for the 3 Centene plans, 2 Qual Choice and 1 Arkansas Health and Wellness plan. As always, we do try to structure all of our plans around the 2 main program goals that are established for this program. And those are, just as reminders, improving the health outcomes of the participants in the ARHOME's program through the use of incentives. And then, as we've always talked about, particularly in maternal and infant health, rural health, behavioral health, and those suffering from chronic diseases. And then to provide incentives and supports to the ARHOME participants to move up the poverty ladder, up the economic ladder toward independence. So for 2024, we will continue to strengthen our existing programs. We have a lot of programs in place, a lot of incentive programs, while we also look to add some additional incentives as well as some new programs. So we don't believe incentives are the only answer to improving the health of these individuals. We also need to have directed programs in place that target various disease states to try and move that needle. So we will be, we'll talk about in just a bit, some new programs we're implementing to target SUD, social determinants of health, behavioral health, and some suicide prevention. So first we'll just remind folks about our existing programs we have in place. We utilize a incentive program called My Health Pays. This particular program has a lot of different ways members can earn rewards or incentives within the program. They're focused on eating right or being healthy, moving, saving, save smart, and be well. So a lot of the things that the metrics that we just went over, there's a lot of different incentives that target each of those. And then individuals earn points that can be converted to dollars. So they can either use points to shop in an online store, or they can actually convert that to dollars. And they can earn up to $500 a year, and those dollars today can be used to pay monthly premiums, but this plan doesn't have premiums. I'll say that. This is our program across the country. So some plans do, but ours don't here for our homes. But definitely the small co-pays, they can use that to pay those co-pays. But they can also, most importantly, use it to pay a utility bill. So those dollars are real dollars. They can be spent on utilities or phone bill, and they can even use it for childcare, transportation, or education. One thing that we are looking at more heavily is what we've just talked about, more marketing, more education, because what I'm seeing is that we have members that earn rewards, they don't ever actually get them because they are required to log into our portal to be able to manage that. And I think that today is a bit of a barrier. So we're looking to how can we remove that barrier for our members so that they can actually receive more of the reward. So the people that received a reward are not necessarily the number of people that could have received the reward. They earned it, but to get it, they have to manage it inside our portal. So I've really been working with our leadership and our corporate teams to try and find a way to remove that barrier where it's just sent to them, because I do think ease of access is so important for these members. And if they thought they earned it and never really got it, are they gonna use it again the next year? It's not getting that year over year continued in outcome. So we are looking at that, and we're also looking at a marketing campaign to really drive home the My Health Pays opportunities so that members know there are rewards, how to get them, what they can earn, and that they really can convert those to real dollars that they can use to pay all of these things. So definitely a focus of ours this year is to get more marketing campaigns, more knowledge about the rewards, and then hopefully we'll see that start to drive those healthy incentives. This shows a little bit about within the My Health Pays, all the different ways folks can earn rewards. One of the first and foremost ways, and we try to drive this home, is have an annual wellness visit. Get in to see your primary care physician, because that visit is going to, launch them into these other things. They typically are asking them about, have you had your breast cancer screening? Have you had, cervical cancer screening? Is it time for a colorectal screening? Those things, those doctors are talking to them about at those meetings or those visits. So we really want them, at a minimum, get a wellness visit, because we know that will help launch that into some additional services that they need. But we also incentivize them for all those individual services as well. So you can see, we've talked about those metrics. You can see there are incentives around there, around those items. Within our My Health Pays portal, we also have incentives that can be earned by getting in the portal, just watching videos and being more educated about all types of things. A lot of things around economic savings, how to get out of debt, how to cut down your electric bills. So really a lot of things to help those folks manage their dollar a little bit better. But we got to get them in there to be able to see it. And I think that's the first step. How do you get them in, get them to the portal?
Do you all know, is it an access issue, people who just don't have access to?
I don't think it's an
connection,
access
or is it
issue, it's just,
They just aren't doing it,
Yeah,
education
and
about logging
education.
in.
right. We've created a new video that if they can, if they get to the portal, it'll walk them through how to log in, how to use but we're also looking at ways to do some incentives that are outside of this, so that, they don't actually have to go into a portal. They will just get if they earn it, it'll
They got
arrive
it.
at their door.
And did you say, or am I making this up, did you say that there's an incentive to actually create your profile in the portal?
There is.
Okay, that's fine, okay.
We educate a lot. Remember, our packets each year have information about it. We do community events. We're always talking about it. We have extensive quality outreach within our organization, where we have folks calling people that's not actually met whatever we call them gaps. They haven't had their colorectal screening. We tell them you can get a reward for doing this. But again, I think it's a little bit like the return on the surveys. It's really something you just have to keep at, because you only get so many to respond with each outreach attempt. So you just have to keep going. So, yes. We also have a couple provider incentive programs that we run to address our quality gaps and to address all of the conditions that the member may have. One we call our continuity of care program, and incentivizes providers for engagement in addressing those chronic conditions. And then our in-office assessment program, where it is really targeted to those primary care providers to address quality gaps for those members. So really that is get them in and have a wellness visit. That's where we start, get a wellness visit. So we try to drive it from both sides, with the provider and with the member. We also have currently some partnerships. We've worked very closely with the Workforce Development Board. They have been with us throughout 2023 at almost every one of our community events. They will attend as well. So they're there talking to folks that come out at those events. We host those across the state. 2023, we were really ramping back up from the COVID years. And so we will continue to do those in 2024 and hopefully expand the number that we're able to do. They're really nice events, and there's a lot of incentives at the event for people to come out. There's a lot of free things for the members around mammogram, maybe the mobile van, the cholesterol screenings. So there's a lot of incentives just to draw the community to the event so that we can then talk to them. We have a Start Smart for Your Baby program that's really a specialized case management program that we target our pregnant moms to try and obviously reduce those low birth weight babies in preterm births. We have also community baby showers. We did not see the uptake on those this year that we had hoped to get, so we are expanding that in 24 to add a virtual option to try and get more and more folks to the baby showers. Again, they're very much like the surveys. We invite 3,000 people and we get 40. So how can we get more people to attend those? They're very educational. They really do. They're honestly a lot of fun if the folks will come out, but we bring people from the community. We bring the pediatricians, the OBs, we bring the firemen, those kind of folks to talk about the installation of car seats. And they even give away car seats and things like that to those that attend. So we're looking to expand that to a virtual offering this year. So hopefully we get more and more people at those events. We also run some what we call Halo program today. That's really looking at folks with substance abuse disorders. It's more of it's also like a case management type program, but it's targeted to identify those individuals that meet those criteria to be in the program. In-home assessments. This is a big one for us, and we do hope to expand on this in 24, which is in the rural communities, there are not always access to all the services. So this actually puts someone into the home. We send someone into the home to do those assessments, clinicians, and they can address those care gaps in the home. And then lastly, we have a pharmacy lock-in program. Not sure the members would agree this is an incentive, but it actually really does help to reduce inappropriate drug utilization where people tend to pharmacy hop. It really locks them into a single pharmacy so that they can't go from one to the next to get those medications we don't want them to be obtaining. And then I did something. So in 2024, we do have a few new programs we are implementing. We are one we call METS SUD, which is stands for Members Empowered to Succeed Substance Abuse Program. Really, it's a BH program that is, again, targeting individuals with significant behavioral health outpatient utilization where their diagnosis is substance abuse or substance use. It's clinicians working directly and closely with providers and also those members to help identify treatment programs for them. We're also implementing a value-based program with Quartet. Again, it's a model that works to treat and identify and treat and provide some financial incentives again for behavioral health practices. This one's a little bit more directed at providers. And then Choose Tomorrow is our suicide prevention program. It is, again, a case management type program where we've trained staff specifically to look for suicide type identifiers to try and help prevent those outcomes. And then lastly, we've implemented Find Help, which is a social platform that will connect members to any social needs that they may have. It's an absolute fantastic social platform opportunity. So we'll be educating members as we're talking about My Health Pace. We'll also be talking about our Find Help. It's out on our website, and it actually go to your area and whatever that is you might need, be it food banks, transportation, housing, lots of resources there by community to help individuals that have those needs.
Is that something that you all, that Centene has implemented nationally? Are you guys using Find Help on a national scale, or is it specific to Arkansas, or maybe just a couple of different states? A little bit both.
A little bit of both. It is part of Centene's national, we have a national agreement with Find Help, but not every state actually takes advantage, I don't think, of using it. But we have rolled it out, and we also sit on the board, I think Blue Cross sits on their local Arkansas board, to just really continue to build that out so that it is, specific for Arkansas and provide those services. So it's a really nice resource. I know Blue Cross is at the table too. So we all participate in that to try and bring those resources to our populations.
Be interested to know your, after you guys have used it a while, what you think of it.
Sure. We're excited to have that as an opportunity for this population, for sure.
Okay. Thank you very much. I do have one other question.
Sure.
What's a virtual baby shower work?
Well, we were just talking about that yesterday, actually. So we will, obviously, it'd be on like a Zoom Teams meeting. We'll invite the folks to come on if they agree and attend. There will be games that they play. They can win prizes. Just for attending, we'll send them whatever they might have gotten if they came in person. Okay. And then we will provide that education just virtually. So as we have pediatricians talk about important things to do for your baby. OB's talking about all the different steps, what you should be doing along the way through your pregnancy. And then if there's any of the, hopefully the firefighters and things talking about, installing your car seats and that. So it'll like interactive TV.
All right. Sounds interesting.
Yeah, we hope we can get more people to attend. We think sometimes childcare and things like that might be barriers. Mm-hmm. And so a virtual option might help to remove that barrier. I think that's really.
Do they access it or get to it by internet or by apps?
Both. We hope to be able to let them get that either way, to make it as easy as possible to get to it. Again, I don't think I can't say that enough. I'm finding that it has to be simple. I think that's the word you used. It must be simple. If it is complicated in any way, you will not see the uptake that you want.
We all like simple.
Yeah. Simple is good
for everyone.
Yeah. And even when you think something's simple, there may still be some barriers. So how can we make it more simple?
Right. So you'll be using a widely, like a Zoom type probably.
Which might not feel as simple for everyone that doesn't use it every day, right? So.
We'll move on to the Blue Cross strategic plan, and we've got Lauren Dixon here to walk us through it.
Awesome, thanks, Mel. I'm going to walk through a bit of background. We've had some significant changes to our programs over the past 2 years, so I'm going to level set a little bit on the strategic plan. Some of what we've done this year and transformed, and then some of the changes that we're looking to make. I want to level set by starting with the Blue Wellness Rewards. Obviously, we spent quite a bit of time today talking about rewards and incentives, and really do feel like that's a cornerstone of the program when we couple it with provider rewards and then other engagements that we do. Obviously, we've talked about communications today, and that is the first part of our program. That is really the way that we choose to educate. Everyone is made aware from the first moment that they partner with the plan. It's also on our website and other resources. And then we send targeted communications as they become available for specific gaps, continuing with the goal, obviously, on the preventative side, but then also using that in our conversations to engage and provide specific information. We do think the registration is fairly easy, but we want to note that it's not just digital. We do have customer service agents that are readily available that can do this for them at any time, over the phone or through any other communication method in case there's challenges, or can even self-register and complete all of the components for them if maybe they don't have electronic methods or other areas to do that. So we do have a couple of percentage points that do it through that method, and then those customer service agents are also empowered on the calls to educate them regarding the program and intervene. When they do sign up though, we definitely try and get some feedback from them, some survey information so that we can personalize the platform as much as possible, but we do feed it with our data analytics. So all of their open care gaps are included on the platform, along with specific information that contains kind of the triggers and other areas. So with that, when every time they log in, they're going to see all of their care gaps, both what's been completed and what hasn't. This one's in Spanish up top, but pretty easy to see. So this member is eligible for $100 in rewards if they have $50 that they've completed so far. If they hit that little blue button right there, they'd be able to access all of the opportunities that they have within the queue. So all of the care gaps that we'll talk through in the next slide. We also trigger other reminders and other things we want them to do that maybe don't have rewards associated with it, but are things we think would be beneficial for their health and wellness, based upon the personalized feedback that they've given us, either when they sign up or through the health risk assessment they complete. I think another part of this that we've also talked about in other meetings is health literacy and the basic understanding of conditions. And so with that platform, we've partnered on health education. Not as easy to see, but if you squint really hard, you might be able to see in the upper right-hand corner, there's a number of health education articles. And so it's focused on specific things that we've all talked about here, CHF, diabetes, and those core conditions. But in addition to that, it also talks about preventative care and the cancer screenings that they might have, trying to explain it in simple terms as to why each one of those should be coupled with the interventions and the care gaps that we're rewarding for. As we look at 2024 though, try to keep this really simple. So you'll see a grid on the right-hand side. Stars are brand new additions that we've replaced. Little arrows are things that we've increased. So I'll just hit the ones that we've changed year over year. We talked about how we were a little bit disappointed in the engagement from a blood pressure perspective, and also saw that the QHPs are really struggling from a chlamydia screening perspective. So we have engaged with that, added a reward for 2024, focused on that membership and looking to increase and identify those cases earlier in the process and then initiate treatment. So $50 for members who would complete that screening. And then also a little bit challenging, but something that we're interested in is rewarding for contraception and postpartum women during that 90-day period. This would trigger earlier in the app, so when they're close to giving birth as a reminder. It also will couple a little bit with our care management program. When those members receive an outreach by our care managers, we'll be able to talk about this reward in combination with that to try and incentivize and then further kind of push that. And then one other thing we'd like to remind is we've also partnered with the pharmacies in the state, since they would have the opportunity to prescribe relative to this and be able to provide that information with the reward. And then on this slide, you'll see a couple changes that we're making based on the feedback that we received in the Q2 meeting. We've gone ahead and updated the reward amount for the continuing education and the career readiness certificate, doubling the continuing education, tripling the career readiness certificate amounts in hopes that we'll see some increased partnership and increased engagement in there. And then also increasing our engagement with health fairs and health community events as we increase those numbers at our local stores and other locations throughout the state. So from a member perspective, we recognize, again, that's a cornerstone, but they can't do it alone. We have to do it through a multifaceted approach if we're looking to reduce the risk of disease, disabilities, and death. And so one of the transformative processes we've been going through internally is making our gaps as close to real time as possible and closing those through other platforms, through providers or through members or through other education. We also use a fourfold approach to closing those gaps, focus on care management, behavioral health, social workers, and then our clinical quality specialists that couple with our digital engagement and other platforms. And so we are trying to meet the member where they are, obviously understanding not everyone's at the same spot, but really using messaging around health literacy and gaps and just general benefit education through email, text, phone calls, print messages, really however we can get in contact with them and whatever we're seeing them respond to. And then ultimately, we'll talk a little bit about this through the presentation, really increase the prevalence of telehealth with our different programs, because if you can capture a member in that moment, you never want to lose them. And we'll especially talk about that when we talk about Bright Heart, but really kind of trying to provide that opportunity for intervention at the right time, and especially in those rural areas. But to use providers as a segment and an opportunity, really view that collaboration as important. We've been operating 2 programs, Patient Centered Medical Home and Primary Care First, in collaboration with the CMS models. But what you'll see here, largely on the left-hand side, is that these align to the ARHOME quality measures and what we're looking to improve. So diabetes, really reducing that readmission, controlling the A1C, also looking at cancer screenings, and the antidepressant medication management. And then ultimately, we also look at the overall ED utilization and inpatient admissions. Some of these are up there just because they are included in the overall program, but obviously understand pediatrics would be a separate population for this. We have seen a great uptake. Over 50% of the members in the ARHOME program are participating with a provider that is in a value-based care relationship. And so 71 clinics, reflecting about 459 providers, participate in primary care first. 255 clinics, representing about 1,085 providers, participate patient-centered medical homes. And with that, again, about 77,000 patients in 2022 were reflected into a value-based care program. We look to continue to improve that number, so we want that number to continue to go higher in terms of patients engaged, participating, and attributed to a provider that can close their care gaps. We do want to note patient-centered medical home will kind of go away as CMS shifts their methodology, so most of the clinics will transition to this primary care first model within 2024. So it might be a little bit of a dip next year, but we expect that to rebound as provider clinics make their transitions into the new model and new practices. And then wanted to, as a takeaway from last meeting, talk about the differences between providers who are engaged within that model and why we're going to continue to lean into it versus those who aren't. So what you'll see is that darker blue color up there are our clinics that are participating in value-based care programs. The lighter blue are those who are not. And pretty much across the board, except a couple measures, we've seen much stronger improvement. And we've coupled this together with provider engagement and value-based care programs in driving up those quality results. So kind of speaking universally that it has to go with member and provider and health plan and everywhere kind of across the board to continue to drive that engagement and overall participation. So we paid out about $6.3 million in incentives in 2022 to providers across the value-based care spectrum. And again, continue to plan to offer that in 2024 and future years. So I want to transition a little bit into our internal programs, talk about some changes that we've made there. The first one, I think, is the cornerstone of any health plans programs, but for case management and making sure that we're intervening appropriately, working across plan, provider, nurses, pharmacies, and the member, of course, to help maximize, understand benefits, intervene in conditions, and then making sure that we're reducing the risk and the comorbidities later on. I won't read you all of the conditions that are in bullet 3, but you'll probably notice that they align to the quality measures and to the evaluations and priorities of the ARHOME program. Coupled with care management, though, and kind of tying a little bit to what Santina's mentioned, social work and the intervention on social determinants of health is so key within this population. And so we do couple that with the program. We receive interventions, either that we've triggered based upon predictive analytics or that the care manager can self-identify to help resolve food, transportation, housing, and other potential barriers. So while not everyone's in care management, we do feel like it's important that everyone has access to someone 24/7 at any point in time. Maybe not a full visit, but at least maybe a nurse to talk through. So we are increasing our engagement. We've always had this in terms of Nurse 24, but we don't think it's necessary that, or we don't think necessarily that everyone knows about it. Again, going back to education, this is so easy. It's just someone to talk to about really any question, and they'll refer you to the right location, help you prep for your visit. So we're going to push this a little bit more and try and remind people that it's a resource available to them literally 24/7, 365 to hopefully then triage. We've also educated them on all of our items. So everything from Teladoc to our Bright Hearts to dispatch here in the Little Rock area so that they can triage the appropriate location for care if someone does need it. This one's probably the one that we're most thrilled kind of about the advancement that we've seen over the past year, but maternal health is something that we struggle with in the state of Arkansas and something that we've continued to see kind of a flat line or even a worsening of early term births. And so we have two programs coupled together. Our special delivery program is an internal case management program. Two ways to be engaged: either PIM members can self-identify, they can get someone to help them throughout their treatment, or we identify very quickly based upon claims, share data. We have previous pregnancy history. We also might look at other preterm births relative to the mom or chronic conditions they have. They're enrolled with a care manager. If they're low risk, we're going to see them at least quarterly or trimester. And then we'll also intervene postpartum, but high risk is minimum monthly. However, there is a care manager on call for them to speak to throughout the week in case something comes up. They talk about all of the good health practices, everything that we can do to try to prevent those preterm births, and then also what they can do post-birth. I think what's really key here is the postpartum intervention. We've seen also a spike in postpartum depression, especially post-COVID. And so they're looking to intervene on that and then provide education on contraception and the follow-up calls after birth. Accompanying this, though, was an introduction of the program Maven this year. Maven is something we're really thrilled about. We've had over 3,500 engagements with Maven in just its inaugural year. And if you compare January to November, a 72% increase. Every single month we've had Maven this year, the number of people and the number of engagements has increased. And so it's a 24/7 pregnancy support platform. It has it personalized to the member where they are in their pregnancy. They can access videos, they can access messaging with providers, there's classes, there's educational articles, but really at any time for anything they can talk to someone. And so it's really easy. You can see how quick and easy it is to schedule up there. And it is something fully covered and with their benefit, and also provide some additional support throughout their pregnancy and then after their pregnancy. But I think the engagement that we're seeing with this is really exciting, and we hope to kind of see that further into the decrease in preterm births later.
And kind of the same question about the Find Help, but is this something that Blue Cross Blue Shield is doing sort of globally, or is this something that you guys are trying in Arkansas, or what's kind of the?
So this is, I think there are a couple other Blues that are using this, but I think we were really kind of the first. We started it as a pilot in this Medicaid population. We picked it up in a few of our other plans, and actually some of our commercial plans are now interested in using this. But I think there's only a few Blues throughout it using it, but more are expecting to engage with it in the future.
That's correct.
Interesting.
Really quick on behavioral health, again, focus here, we've talked through some of those measures, wanting to lean in across the spectrum on the various kind of care pathways that people have and the opportunities of licensed associate counselors, licensed master social workers, and various telehealth interventions. We have increased the care management team and the identification with more prompt data to especially focus on numbers right after they're discharged and help to coordinate their care across the spectrum. So all of the follow-up visits, all of those various interventions, and then making sure they're getting in with the right provider offices. We've also brought on peer support specialists, so they really understand that journey from a substance abuse perspective and from overcoming it to help coordinate with those members and also have the ability to resolve social determinants of health. This is our other telehealth avenue. So Bright Heart is a platform that helps with opioid or other substance abuse disorders, and it really helps a member right there at the time. So if somebody is truly in that moment, it can sometimes be a long time before they can see a provider. It can sometimes take weeks. This will see them very quickly. So you'll see over 50% of patients get seen and have intake within 24 hours of their initial contact. So we're trying to get them right when they say, I need help. They're not having to wait. And so it provides a care team for them, 24/7 virtual clinic, and can intervene with them at any time they're maybe having some challenges or need help relative to substance abuse. So our goal is really, one, to reduce kind of that delay in substance abuse care, but two, what you'll see on the right is also to sustain that. And so I think, Nell, you talked about how it decreases the continuation. Our goal with this program is it becomes much easier to continue care because it's right there in the palm of your hand at any point in time when you need help. We can also obviously alert you and give some reminders to receive that care along the way. And then finally, again, obviously that focus on health equity and resolving access. We spoke quickly regarding the career advancement and also assisting job seekers. So increasing those rewards and the opportunity with it. We continue to try and leverage and reinforce the Arkansas Department of Workforce Services Career Readiness Program within all of our communications and with all of our rewards program. Seeing great results from those members that have completed it in terms of their feedback, and really want to incentivize them for doing that. And then as we talk about improving access, obviously recognizing not everyone can do telehealth, but you've heard, kind of where we're leaning into it today. We also have teledoc for preventative care services and for acute services and other behavioral health, and then increasing our health literacy through that perspective and engagement. And finally, really leaning in from a community perspective. Our foundation has invested over $7 million this year in mental health throughout the state. Most of those are pediatric at the bottom, but we do want to emphasize the refunding of the American Foundation for Suicide Prevention for Arkansas, which we think will help from a behavioral health perspective and providing those interventions, and then also mental health first aid counseling for over 750 people across the state. And then we will have our welcome centers there to continue to provide assistance to all of the members. We're going to increase our engagement events for ARHOME members, try and get them there, try and help them with benefits, sign up for rewards, close care gaps actively on the spot, maybe even see providers and help improve from there. So we're really looking forward to kind of trying to couple all of this together to ultimately improve the care of our Kansans and hopefully the quality measures from here on forward.
So one question I have, and then I invite others to ask questions, not just me, but you mentioned blood pressure was one of the metrics that you guys were not happy with. I didn't see a blood pressure incentive on the patient side, but is there a blood pressure incentive on the provider side, or is there not one?
Yeah, so there is actually a blood pressure incentive, sorry.
And I may have missed it.
No,
didn't
I
see
think
it.
I went through it really quickly. So it is on the provider incentive for controlling blood pressure. We had it as a member incentive last year, but we had less than 2% of members engage with it. We tried to do it as a health education and then basically a testing and a monitoring. And just with such low engagement, we felt it was better to maybe pivot to the chlamydia screening as a test for next year and really re-emphasize this measure in our provider programs and stuff.
Okay, thank you for that.
And one question for both of you, in terms of, again, looking back at the different pilots, the different demonstrations, the ones that were specifically aimed and titled weight loss, and we all know losing weight helps you with your diabetes, with your hypertension, everything else. But in people saying, well, that's the objective, none of the states were successful. Because again, somebody getting on that scale, that was determining success or not. So is there another way that rather than measuring BMI, is there another way to say, well, you're eating healthier, you're getting better exercise, and those are the things that are just as important in status?
I don't think we've necessarily been able to go down that path easily from a rewards perspective. I'll tell you, it's coupled inside the care management programs for counseling. And then within those health literacy articles, it does emphasize healthy eating, fitness habits. They can redeem any of the rewards for fitness-related activities. But we have struggled, I would say, to find a way to redeem that. And I would honestly a little bit also have to defer to Matthew. I don't think we've had specific incentives that we've set are for weight loss or within that platform. And then we've honestly kind of tried to move away a little bit from BMI in terms of those evaluations.
I'm happy to have a cup of coffee with you, but obesity is a complex and difficult area. And the literature is large and frustrating.
But it's definitely something, Dennis, to your point, that we can continue to take a look at, because BMI sometimes is challenging just to get from the provider, because providers don't like to a lot of times even do that screening. So we can continue to look at ways that we can potentially get to that same result, but do it in a maybe a little bit more creative way. We'll have to think about how best to make that redeemable, so it's a tangible thing for them, but that's a good feedback that we can take back.
There was one in particular aimed at children, and the children actually were getting more exercise, they were eating better, but they gained weight, and they gained weight probably unrelated to, they were gaining weight because they're getting older and they're growing up, right? But the measure was, did you lose weight?
Well, the old line was that kids would grow out of their BMI at least.
They're growing.
But that's a challenge too.
I think I will also point out, like you might see the bottom right hand corner up here has a biometrics and wellness testing. So we did try this, and just for context, in Medicare, we actually tried to incentivize like engaging and connecting with the platform, and we even had Fitbits as kind of a reward during the COVID years and everything else. And they're just really reluctant to give us that data. Like, I think they think we're gonna use it against them. We would never. But like, I think we really haven't seen, unfortunately, like uptake with using the biometrics and wellness screening. We continue to try and emphasize it as more like a monitoring overall. But like you said, we'll continue to look for pathways, but it's just sometimes hard for them to wanna engage with that.
Other questions? Anybody else? Anyone online?
Well, if we don't have any other questions, the last thing was just to talk about the next meeting will be in March. We don't have a date yet. We don't have a location, probably. I like this setup, but who knows what we'll do next. And I'm thinking we're gonna be talking about maternal and infant health issues. Maybe get some folks from UAMS to come and talk about what they're doing. But that's all to be worked out. That's all I got.
Yeah, and I don't, do you all have anything else? Anybody in the room have anything else that we wanna, any more?
Not for me.
Okay, well, I think that concludes the discussion. We appreciate our health plan partners for coming in and walking through the metrics with us, but also presenting the plans going forward. And we will give you all back 10 minutes or 5 minutes, I guess. Thank you all very much. Thank you all. Thank you.
Thank you.
Yep.